being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic will bring up a number of questions from you. So you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request Dr. Prathap to start this session. Welcome, sir. Over to you.
Thank you, Navneet. Good morning, all. Today, the topic given to me is the FAPI and the Theragnostic'S. Before which, we'll have a discussion on certain PET scan and the nuclear medicine scans relevant to the surgical oncology. Coming to nuclear medicine department per se, it is both a diagnostic and therapeutic branch. Where diagnosis, it was the conventional functional imaging for a couple of years, which used to be like a gamma scans, like thyroid scan, DTPA scan. This functional imaging were used to be under the nuclear medicine conventional imaging. Next is with the advent of PET CT scan. There is a revolutionary changes in the imaging. One with the metabolic imaging, which we do with the FDG PET CT scan. Then is the receptor specific imaging. Receptor specific imaging per se include Dotanok PET CT scan for somatostatin scans, then FAPI scans to image the FAPI receptors, like that PSMA PET CT scan for the prostate cancer. Then what we do in nuclear medicine per se is what we harness the power of alpha, beta and gamma rays. Alpha rays, beta rays, they are very much powerful rays, whereas gamma rays, they are less powerful, and we use that in a very minute amount for a diagnostic purpose. The benefit of gamma rays is this gamma rays, they travel more, they are less powerful, and their half-life will be very much short. For example, if I am using technetium-99m, that is the metastable technetium, which is regularly used for conventional gamma imaging, its half-life is only 6 hours. It can be tagged with whatever agent we want for the organ of interest, what we want to scan. Then it is injected to the patient, then the scans will be done. Whereas beta emitters are used for therapy. Beta emitters like lutetium, iodine-131, which we regularly use in many therapies, also has little amount of gamma component. Therefore, they are also used for imaging purpose too. Whereas alpha, they are strong, very strong radioactive molecules. Therefore, they are used for therapy. And the good thing about alpha is they travel only 1 to 2 cell layer. That's all. Their range is very much less. Therefore, they have almost literally no side effects. This is the gamma camera or SPECT, what we call it as. Here, what we have these two detectors. One detector is here, one detector is here. Hence, we call it as a dual head gamma camera. Once the patient is injected, the patient is placed in this particular region, and the images will be acquired in this gamma camera. For example, if I want to do the thyroid scan, I will inject him the technetium-99. Thyroid scan is also done with iodine-131. That is for the different purpose. Here, to differentiate between the hyperthyroid and thyroiditis, we do that 99m technetium scan. After injecting, the patient will be, his neck will be placed in this area, and the image acquisition occurs over here. Like in CT, like in radiology, what we have is X-rays, CT scans, MRI. We have two different scans over here, machines over here in nuclear medicine. One is the gamma camera, one is the PET CT. And the therapy part is like iodine therapies, lutetium therapies, actinium therapies. They have different indications for that. Gamma scans are functional scans like thyroid scans, parathyroid scan, myocardial perfusion imaging, which was called as stress thallium scan in all these years. Nowadays, stress thallium is not done because we have got better agents than the thallium, which we call it as technetium sesame scan or sesame or tetrophosphine perfusion scans, which are better than the stress thallium, but the name has remained like that. Then coming to the kidney scans, we have DTPA scans by which we can do we can know the GFR of each kidneys. DMSA scans to know about the scarring status if there is any. Then bone scans, brain to know the foci of epilepsy, and GER scans to know about the reflex studies. In PET, apart from OncoPET, there is other indications in rheumatology, cardiology to know about the hibernating myocardium, in neurology to assess the dementia assessment, and also in the Parkinson's disease assessment. This is the technetium generator what we get. We usually once in a week this comes from the nuclear reactors. The technetium what we get its half-life is 6 hours. How we get the technetium is, here we have this empty vial. If we insert over here, the technetium comes from this generator and it will be in a form of liquid, and after which we take into and we measure it, and how much ever the quantity we will tag it with the different agents for which we want to image. For example, if I want to do the cardiac perfusion, I tag it with this kit, and that is a radiochemistry part. It takes a couple of minutes to do that, after which it will be injected to the patient. Then the scans will be acquired. In cardiac imaging, I will acquire the cardiac part. This is a DTPA kit. I will tag this DTPA to the technetium. Then it becomes technetium DTPA, and it will be injected to the patient. This DTPA helps to get localized or to see the function of the renals. And technetium gives the radiation, which will be captured by the detectors which are there in the gamma camera. This is our room where it is all radiation protected and it will be measured. You can see this is the area where we prepare and after which we inject. This is the basic principle. For example, if I want to tell about the cardiac imaging, tetrophosphine will go and bind at a tissue level to the cardiac myocytes. Then the technetium will give the radiation, which will be detected by the detectors and gives the image. This is the image of the technetium thyroid scan. This scan is done to differentiate between the hyperthyroidism and the thyroiditis, because some cases there might be biochemical overlap. In hyperthyroid, we can see a diffuse increased tracer uptake in the thyroid gland. These are the salivary glands, and this is the thyroid gland. In thyroiditis, there will be no thyroid uptake, and only the salivary uptake will be there over here. And next, there is also something called iodine-131 scans and therapies. Iodine-131 therapy, which is of low dose, is used for hyperthyroid treatment, and also iodine scans and therapies is used followed by thyroid surgeries for thyroid cancers. Which is the sesame scan image, which is done to look for the parathyroid adenomas. We can see here the sesame will be injected and the continuous imaging will be taken at 15 minutes up to 3-4 hours based on the requirement, and the parathyroid adenomas get localization of this sesame bee because of the high oxyphil cells in them. Then this is an image of the technetium DTPA renogram done to look for the GFR estimation or the functional status of the kidneys. Anatomy and the functional status might not correspond always. There might be 2 kidneys, but there might be functional 1 kidney. This is to see which kidneys are functioning. Here we can see only these are all the posterior images. That means that the image has been acquired from behind. Since the kidney is behind, here we can see only the right kidney is functioning and it is again excreting, and this is the urinary bladder. The left kidney is non-functioning. And we will get to know about the GFR over here. GFR, how much is the GFR per minute, we will get to know in the ml per minute. Then coming to PET CT scanner. This is the image of the PET CT scanner. It is a amalgamation of 2 different equipments. One is the CT scanner, the second is the PET scanner. You can see over here the starting half, this is the CT part, the behind part is the PET component. In one go, initially the CT will be done, and the patient will move inside and the PET acquisition is started. How usually the PET CT protocol happens is it varies for what radioactive material which I am using. For example, if I am using the FDG PET CT scan, we will advise the patient to come in a fasting state. His blood sugar level should be within 200, ideally within 150. Then after 8 hours of fasting, we'll give the measured radioactivity of FDG that will be injected. Then after 45 minutes to 1 hour of waiting time, the scan acquisition will happen. The imaging time under the machine, under this PET CT scanner, will vary between 6 minutes in a digital PET CT scanner, and in a conventional PET CT scanners, it goes up to 10 to 12 minutes. Then once I see the PET CT image, how does it look like? This is a PET image. It's only a PET image, MIP image. We can see the brain uptake, which is normal physiological brain uptake, what we call it as. And apart from the brain uptake, there is something tonsil uptake, myocardial uptake, GIT, it is the route of excretion. These are all normal physiological uptake, nothing abnormal over here. Therefore, it is very difficult to differentiate the lesions in the brain in FDG PET CT scan and also in the renal. And this is the image of the medical cyclotron. Medical cyclotron is the equipment where the FDG is produced, this will not be available everywhere, but the FDG after production from here will be distributed to the places where there is a PET CT, and half-life of FDG, F18 FDG, what we call, is 110 minutes, approximately 2 hours. And this will be shipped to the area, and in the place of PET CT scanners, this will be injected and the image acquisition will be done. FDG PET CT scan. How I read the FDG PET CT scan? Once I open my screen, I get all these 4 images. The first is the CT scan over here, which I am showing. It is the axial slices. The next, the right one is the PET image. It is just a PET image. The lower left one, which I am showing you over here, is the fused PET CT image. The right corner, the one which I am showing here, is the MIP image, where I can see the complete whole body image in one go, and I can localize. For example, if I want to see what is this black dot, if I click here, it will come and show it over here. Therefore, what I mean to say is, just with a one click, one go, within few seconds, I can have a rough estimation of the staging with the PET CT scan. For example, in the next slide, we can see this. There is a lung uptake over here, which can be localized through clicking on the MIP image, and this gives me a rough staging within few seconds. And detailed reporting will be done later, going with the organ wise. This is a PET CT scan which is being done for the biopsy, done for the lymphoma case, which was here how the FDG PET CT scan is done for the lymphoma. That is the best for lymphoma. Stage 1, there is only one on the one side, likewise. And how other things apart from staging, the FDG PET CT scan or whichever the PET CT scan, it helps to take the biopsy. Because we can take the biopsy from the highly metabolic area, therefore which gives highly positive results and allowing the less negative results in the biopsy, and also for the response assessment after the treatment. Then also few of the cases what we have seen in pyrexia of unknown origin is the vasculitis. This is also FDG PET CT scan. We can see the good vascular uptake over here, vessel uptake. This will be responsive after giving some steroids or any medications particular to that. And we can see the response assessment through the same FDG PET CT scan. There are some technical issues, preparation issues, blood glucose issues, and the sensitivity issues with this FDG PET CT scan. The technical issue is we can't have this in-house in most of the places. We are reliable, means the FDG should come from different place from the cyclotron. It usually sometimes because of the many issues it might not come, or we can't do it in the night time. These are all the technical issues with the FDG and fasting, and if the blood sugar is more, we can't do this. Because of all these things, what the new things what we have is the gallium based PET CT scan. The machine will be the same, the PET CT scanner will be the same, but what we inject to the patient is different in these gallium scans. This is the gallium generator, and this is all the radiochemistry part, where our radiochemist will prepare what are the drugs, what are the radio traces what we want. For example, if I want to do the PSMA PET CT scan, the same gallium will be undergoing many steps, and finally we'll getting a product gallium PSMA. Next, if I want to do the gallium FAPI, which I will come to it later in detail, that is, we will tag it with the FAPI molecule with the gallium. We will get it with the gallium FAPI, which is for later which we will inject that to the patients. This is an Dotanoc PET CT scan. Neuroendocrine tumors, most of them, if in low grade, that is grade 1 and grade 2, will be FDG negative but DOTA positive. Since they express the somatostatin receptors, this Dotanoc will go and bind to the somatostatin receptors, and gallium helps us to give the images or the radiation which will be captured by the machine. We can see over here, this is the FDG PET CT scan of the same patient, and this is the gallium PET CT scan. In the gallium PET CT scan, we can observe here there is no brain uptake. This is the first thing, whereas in FDG it is there. Second thing, it was a case of lung carcinoid. We can see the very good gallium DOTA uptake in the lung, which can also see there is a liver metastasis too, which is all not picked up in FDG PET CT scan. Therefore, only FDG PET CT scan, single molecule FDG PET CT scan is not a fit-all molecule for all indications. The molecule or the radio tracer what we inject depends upon the indication, and it is tailor-made for the indications. You can clearly see there is a liver metastasis over here, which is not picked up in a FDG PET CT. And this is the gallium DOTA. Here we can pick up the liver metastasis. Then this is one more example where we can see the Dotanoc PET CT scan, liver is fine. We can see this. This was a case of jejunal NET with liver metastasis, very big lesion, and later he was given lutetium dotatate therapy. We usually give intra-arterial lutetium dotatate directly to the liver with the help of interventional radiologist. The funda is to deliver the maximum dose in the first pass, therefore avoiding less renal excretion and getting the maximum benefit with the smaller dose. And this is the new thing which we call it as AldoPET, which is an alternative to adrenal venous sampling for adrenal aldosterone producing tumors. Even this doesn't require any fasting, no preparation, nothing like that. Whereas adrenal venous sampling is a tedious procedure for hypertension imaging, where all drugs should be stopped, then the images will be done. Here, just a small injection after 40 minutes, if there is any uptake here, color is seen. This is known as aldosterone producing adenomas or functional adenomas. Whereas non-functional adenomas, even though there is a tumor, it will not take up the uptake. This is one thing. Here, this is the patient image. This is AldoPET, which is also known as gallium-68. We label it with the CXCR4. It is a new molecule. CXCR4 PET CT. We can clearly see the functional adenoma over here. Whereas in hyperplasia, we see the bilateral uptake in the adrenal glands. This is an MIP image and the PET CT fused image of a PSMA PET CT scan, where we can see the diffuse metastatic disease in the bone. Next is the imaging of tumor microenvironment. This is the new thing in the block, and this FAPI is the new thing, new kid in our block. What we have, this tumor microenvironment, as all of us know, is constituted of cancer-associated fibroblast, macrophages, many other cells. What does this cuffs? What we do here? Cuff imaging, what we call it as cancer-associated fibroblast imaging. Any tumor cell is protected and surrounded by the fibroblast, which we call it as cancer-associated fibroblast, and after which they express the receptors called fibroblast activating protein. FAP receptors will be expressed by this cancer-associated fibroblast, and that cancer-associated fibroblast will be imaged through FAPI imaging, FAPI PET scan. It is not the direct cancer cell imaging, it is the imaging of the associated surrounding fibroblast imaging is the FAPI imaging. Recent studies of doing the PET CT scan in most of the solid tumors, apart from lymphoma, we have seen that FAPI PET CT is very good, more sensitive in diagnosing primary lesion, nodal disease, and also the distant metastasis. A lot of head-to-head comparison studies have been done. This is a new molecule which has been arrived in last 4-5 years, and a lot of studies have been done, and it is been shown beyond doubt that this FAPI PET CT scan is better than the regular FDG PET CT scan in sensitivity and in the detection of primary, nodal, and metastatic diseases. And what's the advantage of PET CT scan doing with FAPI? The first thing is it doesn't need fasting. It is a walk-in PET CT scan, what we call it as. The patient come walk into the department. We have the gallium generator in the department. We have the good radiochemistry team which can prepare the FAPI within 5-10 minutes. And then we will inject the same FAPI, gallium FAPI to the patient, and the image acquisition begins within 10th minute. This all the serial studies which we have done on in a same patient, and we have observed at 30 seconds minutes how the image comes. At 90 seconds we can see the image coming. Just after injection, within 90 seconds we will see the localization of FAPI in the tumor. And 5th minute, 10th minute, 60th minute, we have compared all the SUV values, and now the standardization is within 10-15 minutes after an injection of the FAPI, we can do the PET CT scan with very good image. And now within after 10th minute we do. That means there is no waiting after radio tracer injection as in FDG. FDG requires 45 to 1 minutes of waiting in the department. Then sugar level is immaterial, and it can be done at any time, literally any time, even in the middle of the night. And second thing, how does a FAPI PET image looks like? This is the MIP image of the FAPI PET CT scan, where we can see there is no brain uptake. This was a case of severe breast metastatic disease. It was metastasis to liver and also the brain. We can see very good contrast image over here. The brain lesion is taking very good FAPI uptake. There is no background brain activity at all, as in FDG. Therefore, it is very good for staging. This FAPI PET CT, this is the image of the year in 2022 or so from the Nuclear Medicine Society of the World, where FAPI PET CT was done in different cancers, and the image was given. It was in breast cancer, it was in lung cancer, colorectal cancer, pancreatic cancer, cancer of unknown primary, all these things, even in ovarian cancers, all these things, FAPI PET CT has outstandingly done very good. These are the unique features of FAPI imaging. Fasting is not required, glucose level is immaterial, scan starts within 10 minutes after the dose administration, and we use less of gallium dose, like 2-3 millicuries, 3 or that's the maximum, 3 or 4 millicurie of gallium, whereas FDG we use around 8 to 10 millicuries, and the image quality is better with gallium PET CT scans. And malignancies that have been associated with high FAP expression or all this GIT malignancies, salivary gland, mesotheliomas, colons, bladder, head and neck malignancies. And this is one-to-one comparison, head-on comparison between the FDG and FAPI. We can see nasopharyngeal carcinoma, FDG is not that great. We can see very good uptake in FAPI. Same with the lung. Gastric too is really good. And pancreas, there is a lot of difference between the FDG, where FDG might looks normal, FAPI might pick many other lesions and metastasis, and also in liver disease. where there is good expression of FAP, all these solid tumors gives very good results. And ovary, you can see this ovary above is the FDG PET image, which looks almost like a normal, and the peritoneal disease assessment, where we can see all this peritoneal disease, all these black things over here in the FAPI is a disease which we can see over here. And for all this peritoneal surface malignancies evaluation, this is the best thing available now, better than the MRI. And also the unfavorable histology for FDG, where there was poor FDG effect, like signet cell carcinoma, liposarcoma, renal cell carcinomas, few of the mucinous carcinomas take up very good FAPI uptake. For example, this is the signet ring carcinoma of colon, where we can see very well FAPI uptake. And also good thing about this FAPI imaging is there is no physiological bowel activity which we see in FDG PET scan. Therefore, there is very good contrast imaging which happens with the FAPI. And in imaging the dual malignancy, this was a PET CT which was done for the CA breast. Then when we looked into, there was a renal lesion over here. There is no much difference in the overlap of this physiological uptake, where we can very well see this FAPI uptake in the kidneys also in the delayed images. And for oral malignancy, it is very good because there is no physiological salivary activity as seen in FDG. And this is the comparison between the FDG and FAPI. In the case of CA appendix, we can see the diffuse peritoneal disease, which is missed out in FDG. All this black spots is the disease. And it was a case of CA rectum, which is on follow-up. We could able to detect the brain lesion, brain metastasis over here, which we can see in the CT2 in the FAPI PET CT scan. Definitely it would have been missed in the FDG. And what's about the RT planning? Definitely RT planning is likely to change with this FAPI, because in FAPI what we do is we just not image the cancer cell, we also image the surrounding fibroblast. If we see head to head, we have noticed it is about 20% more volume it gives with imaging with the FAPI PET CT scan. Definitely this is the FDG PET CT scan, this is the FAPI PET CT scan. This is in case of CA pancreas. We can see the FDG PET CT scan, the volume is this much, the FAPI volume is little more. Then coming to MRT, that is molecular radiotherapy, which is nothing but a radiation therapy which is given by nuclear medicine people, since what the molecule which we used are the open sources, which means the radioactive molecule in radiotherapy, the machine gives the radiation and it is localized to one region. But whereas in nuclear medicine, the radiation is given in a liquid way and it is injected to the patient, and it is designed in such a way that it goes and localizes on the tumor cells or the fibroblasts, and it gives radiation over there and it stays for a couple of days. The liquid what we inject for giving the radiation for therapy purpose, it stays a couple of days based on what material which we have used, and it keeps on giving the radiation. Then the next doubt what happens, does it not do any harm to the nearby cells? The range is very much less. That is the beauty of it. The range will be like 1 to 2, 3 cell layer, and it affects only the nearby cells, 1-2 cells only. Therefore, no major side effects which we see. We will see in this. In fact, in surgical oncology, after radiation, the tumor gets still more fibroblast. It is very good for the surgeons to operate for post taking these therapies too. Role of FAPI PET CT in cancer. What is FAPI? For example, this is the tumor cancer cells. It is surrounded by the supporting cells, which is known as CUF, cancer-associated fibroblast. What does it do? It protects the cancer cells. It gives just like a security for the prime minister. There will be one prime minister which will have 20-30 securities. Like that, these cancer cells have a very good security. That is the fibroblast, and we are imaging this fibroblast. That is, we are imaging this, targeting and imaging this securities. What I mean to tell. Then what they do, they protect the cancer cell, and they are also responsible for the chemo resistance. They don't allow the chemotherapy agents to go inside. All these things are done by FAP, are done by cuffs. Then there is something called, this is the FAP receptors which has been imaged. Then lutetium, actinium, which are the beta emitters and alpha emitters, can be tagged to the FAPI and it can be injected, which goes and binds over these FAPI receptors and it destroys this microenvironment fibroblast, cancer-associated fibroblast. This is known as the soil seed theory, where seed is the cancer cell, soil is the microenvironment, which is this cancer-associated fibroblast and all. Here, what we are doing, by targeting this fibroblast, we are destroying this fibroblast and we are removing of the soil. Then the seed can't grow. The cancer cells will be attacked by our own immunity if this protection is removed, and very small amount of chemotherapy will start responding. The cancer cell starts responding for very small amount of chemotherapy followed by the FAPI therapy. FAPI therapy will be done by lutetium or actinium. Lutetium is a beta emitter, actinium is an alpha emitter. Some of the examples what I want to show with FAPI therapy is, this was a case of CA ovary with peritoneal metastasis, which progressed on all line of therapies. She needed ascites drainage 2 times a week. Then FAPI therapy was done with the lutetium FAPI. That means lutetium FAPI was injected to the patient. It goes and binds there, destroys the microenvironment and destroyed the microenvironment, and the chemo was added, small dose of chemo, followed by the lutetium therapy, and the patient doesn't need ascites tapping for the next 4 months, and she survived for 8 months more. This was other patient where the therapy was done with actinium FAPI. This was a FAPI PET CT scan where we can see it very nicely. There is a distant metastasis over here, and also the peritoneal disease, which are expressing FAPI. All these black are FAPI expressing areas. It was progressing on chemotherapy. Actinium FAPI was given. Actinium is a very alpha emitter. Actinium is an alpha emitter. It causes double standard break. These are very much powerful. But the only thing is actinium is little more costly than the lutetium. Once with the actinium FAPI therapy, the entire disease, the response was like this. This is the urinary bladder uptake. The patient was very responsive, and she is alive even after 44 months after this therapy. And FAPI therapy, where all this FAPI therapy can be used, wherever there is FAPI receptor expression, this FAPI therapy can be used. Except in lymphoma, most of the areas this FAPI is expressed. That means the tumors has tumor microenvironment. First, we can image with the gallium FAPI. Then the receptors are good. Then that can be targeted. Then the receptors, the fibroblast surrounding the cancer cell, which has a very good protection of FAPI, can be broken up by the radiation, which is a liquid radiation, targeted radiation. Hence, it makes the cancer cells very much responsive, and this can be used. This was a case of adrenocortical carcinoma, post-chemo, which is the post-surgery FDG PET CT scan, which was progressing after chemo. Then the FAPI therapy was given, followed by immunotherapy. The disease, this was the prior to the surgery, prior to the FAPI therapy, the disease was like this, and there was a very good response. Post-FAPI therapy, followed by immunotherapy. Yeah, and this is a new molecule which all nuclear medicine physicians are looking forward to. This is the FAPI, and we are all trying to shift from FDG to FAPI for the diagnosis and for the therapy, because it is new molecule, very attractive. Thank you. In controlled diabetes, if blood sugars are high, is it? 1 second. In uncontrolled diabetes, if blood sugars are high, is it contraindication? For FDG PET CT, it is yes. For FAPI, it is no. He can have a sugar drink and come to the department, and we can do the FAPI PET scan. But the thing is, what's the indication? If it's for a FDG, definitely the blood sugar should be controlled. If any for other reasons, we can go ahead and do the FAPI PET CT scan. This uncontrolled diabetes, if blood sugars are high, is it contraindication? What are the actual indication? Where do we do FAPI, sir? In any oncological scans, what we do in our department over here, everything is FAPI except where we can't do FAPI. That is where lymphoma cases, we don't do FAPI. There is no good FAPI expression there. For all other head and neck tumors, lung cancer, breast cancer, ovarian cancers, GIT cancers, we directly do FAPI. Even the FAPI PET CT scan, we do it evening 8 o'clock also, night 8 o'clock also. The same patient after the OPD, we do the PET CT scan with FAPI and we send them back. What are the actual indication we do? Okay, this is done. How many sitting of FAPI can be given? Yeah. It is the lutetium FAPI what we use. Lutetium we give usually around 200 millicurie per sitting. Up to 1000 millicurie we can go in a gap of 2 months. One FAPI therapy will be given, and then followed by which chemotherapy will be given 4-5 days after the FAPI therapy. Why? Because the lutetium FAPI would have destroyed the surrounding fibroblast, and it would have made the cancer cells responsive to the chemo, and all the fibroblast might have damaged by 4-5 days. This is what we have seen. Then if you give the chemotherapy, we add on the chemotherapy, the response will be very good. And how many settings? Up to 4 or 5 we can give it in a gap of 1 year to 2 months apart. And every FAPI therapy should be followed by chemotherapy, at least whichever possible. Only FAPI therapy response is not that great. And coming to the FAPI therapy, is there any side effects? Literally no side effects. Patient can take this FAPI therapy and go. It can be done as a OPD basis. No need for admission, as in iodine 131 scans. This doesn't have much of gamma rays. These are as per the AERB norms also. This can be given as a OPD basis, and no side effects, so no vomiting, nothing like that. And the only one thing we should remember while using this lutetium FAPI therapy, we must use the high quality non-carrier added lutetium, which we are importing from Germany, and we are giving it because the carrier added lutetium is known to cause some bone marrow side effects. Carrier added lutetium has some impurities which is known to cause, but non-carrier added lutetium, which is prepared properly with a good radiochemist, with good radio labeling, it should be more than 90 or 95%. With the FAPI, for example, if I adding lutetium and FAPI, the labeled component should be very good. Lutetium FAPI should be more than 90 or 95%. If it is less, the side effects are expected, and even that should be checked in a machine. There is a equipment to check that. How is the labeling efficiency and all that should be, we call it as TLC scanner. That should be checked in-house. If we are preparing in-house, we should follow all this protocol, getting a good quality lutetium, doing a very good labeling, and having the good labeling report too. Then if we do the therapy, there are literally no side effects. Okay, side effects of FAPI is covered. How much is complete clinical response rates for different cancer? Okay, we have done FAPI therapy with ovarian cancers, neuroendocrine carcinomas, and more than 100 FAPI therapies has been done. At least 60 to 80% of the patients, they have got good clinical response. They are responded in one or the other way, and 10-20% we are not seeing a response based on their tumor biology. In some patients we got new lesions coming up after giving new lesions. It was a progressive disease. Whatever the already lesions were there, they were decreased. Might be because of the tumor biology, and the response was really good with the FAPI therapy. Can you show the initial few slides? Okay, fine. I will come back to that. So FDG has no role now. It has been replaced by FAPI. Yes, definitely in our center, wherever FDG, wherever we can do FAPI, 90% we have replaced it. And in the meantime, it will be done in all other centers too. Is it combined with any chemo or target? Whatever the FAPI therapy we give, it should be combined with the chemotherapy or whatever the targeted therapy after 3 or 4 or 5 days. How much the cost difference is there? The cost is same for both FDG and FAPI PET-CT in our center. Availability it is technically demanding, needs very good team, radiochemist. Therefore, availability is not that great in every places. It's available only in some few of the centers. We can name it. It might be 3 or 4 centers who might be doing regular FAPI in entire country as of now. And we are. This has been done in Germany and few parts of China. Germany, China, and India. We are the leaders in FAPI. We are ahead of US. I'm happy to. I'm very much proud in this. In nuclear medicine, we are ahead of US, and we are in par. In our center specifically, we are in par with Germany in case of nuclear medicine, imaging and therapy. It can differentiate non-malignant condition like TB from yes. This is one thing. We are also fibroblast might also be seen in any inflammatory conditions and also in some infections. Therefore, we can't differentiate non-malignant and TB. Even here, it's like FDG, biopsy is needed. Side effects, no. What's the cost difference between FDG? It's no cost difference in ours. Is grade of differentiated tumor well or poorly? Is grade of differentiate of tumor well or poorly affected FAPI? I didn't get this. Dr. Vishnu Kumar is grade. Okay, this is good. For example, in neuroendocrine tumors, if it is poorly differentiated, is very good. And all other cancer types, it doesn't make any difference. There will be good FAPI uptake if there is FAPI receptors there. How much is the radiation exposure risk of after FAPI? Yeah, it is almost the same. If we ask about the radiation exposure, not only in FAPI, in any nuclear medicine diagnostic scan, it is negligible. It's as per the recent American radiology group, even the radiation risk from the nuclear medicine scans is almost negligible. Even these scans can be done in pregnancy also. For example, if I do PET-CT scan, the radiation risk is not because of the PET component, the high radiation, it is because of the CT. Therefore, if required, even in pregnancy, the PET can be done along with the MRI. Therefore, hearing the name nuclear medicine is little biasing, but still the nuclear medicine radiation is less in terms of diagnostic. Therapy, definitely yes, but in therapy the radiation will be given to the tumor, not to the other areas. Is that mainly based on beta rays or alpha rays? It is. FAPI therapy is based on both beta or alpha rays depending upon what we are using. If I am using actinium, it is alpha rays. Which I am using lutetium, it will be beta rays. The beauty of alpha rays is more powerful than the beta rays. Alpha rays are very much powerful, but at the same time, it is more costly. What's the cost of each FAPI? For therapy or lutetium FAPI therapy, it is costing 3.8 lakhs around. Isolation needed for FAPI scan? No. Even FAPI therapy, the patient can be sent the same day. Cost difference between FDG and FAPI PET, it is almost the same. Can this be used in post-operative settings as there is a adjacent? Yeah, definitely. The fibrosis will be a false positive uptake. In that time, just as like inflammatory uptake seen in FDG, it is the same. Like inflammatory uptake will be seen in FDG, fibroblast uptake post couple of up to 3 to 6 months we have seen in that local area. In that time, we might need to have a close follow-up. Time duration in between FAPI scan and FAPI therapy, we can do it on the same day also, but there is the technical issues are there. We can't get the lutetium the same day. and lutetium should be ordered. It will come from Germany. It takes 1 or 2 weeks for the lutetium to get into. Therefore, practically, it can be done on the same day, but theoretically it can be done on the same day. Practically, because of lutetium thing and all, we can't do. How much effective is FAP for T staging? Yeah, it is better. Many head-on studies have showed that FAP is better than FDG because it images the surrounding fibroblasts also. Tumor volume will be more. FAPI for T staging. Limitation of FAPI, PET and therapy. Yeah, FAPI PET limitation is one thing is, first of all, it is the technicality. It cannot be done in each center because of the technical expertise is required, and the maintaining the cost at the same level, that is one limitation. Then second thing is, it can for anything like lymphoma we can't do. And for example, we are not doing in case of unoperated cervix uterus cancer because there is physiological FAPI uptake in the cervix and uterus. And therefore, in post-operative case, we don't have a role. We don't have any objections to do, but we are not doing it in an unoperated case of CS cervix and uterus and in lymphoma. These are the limitations. Is there any SUV value for FAPI? Yes, definitely. We have a SUV value which comes for FAPI, gallium FAPI scan also. After how much interval can chemotherapy given? Yeah, after 4 or 5 days, because within that time the fibroblast would have been little damaged by the radiation, targeted radiation, and that makes sensitive. Tumor-resistant tumors becomes chemosensitive after that. Will it replace CRS? It can challenge. How does tennis differentiated thyroid cancer responds to FAPI? Yes, definitely. In dedifferentiated thyroid cancer, we have seen FAP expression, and FAPI therapy has a role in this tennis. What is the reason why PET CT can't be done during night? With FAPI, we can do at night also if we have the generator. SUV value minimum for FDG, there is no such cutoff for FDG minimum value, maximum value, SUV range, nothing like that. Because some low-grade tumors might have less FDG, high-grade tumors might have high FDG. And for example, to differentiate between the infection and inflammation in FDG, infection and neoplastic inflammation, thing in FDG PET scan, what we can do something called dual point imaging. What does it mean? For example, after 45 minutes, I did a FDG PET CT scan accretion. SUV value I got around 10. If I am suspecting whether it is infection, inflammation, or malignancy, neoplastic etiology, I will repeat the PET accretion again after 1 hour. That is, after 2 hours again, the image will be taken. Usually in malignancies, the SUV will go high. It becomes from 10, it might go to 12, 13 like that. Whereas in case of infection or inflammation, the SUV value remains almost same, 10, or it might drop. It should become 9, 8 like that. This is one rough estimation. The sensitivity of this dual point imaging is around 80%, but still we can have a rough idea in case of if we have any doubts whether that is an inflammation or it is a neoplastic etiology, and that we can ask to do for the dual point imaging in FDG PET scan. Can FAPI rule out inflammatory lesions from METs? No. Yeah, that is inflammatory lesions. We have seen FAPI taking the uptake. Therefore, sure, it is just like an FDG. We can't rule out METs and inflammatory lesions. Biopsy is needed. Is there any advantage of FDG over FAPI? Yeah, definitely FDG in lymphoma, as we told before. In prostate cancer, PSMA PET or FAPI PET, which is better? Definitely, prostate cancer, PSMA is good until unless receptors are expressing. Once PSMA receptors becomes neuroendocrine carcinoma, when it turns it to, what we do in PSMA is the PSMA PET scan. Then we in our center, what we follow is FDG PET scan also. That means if there is FDG expression, FAPI expression is more likely to be there. If only PSMA expression, no FDG expression, that means FAPI expression is less likely. If PSMA expression and FDG expression, we look into FAPI also, there will be FAPI expression. While we are giving therapy, what we do, we get a target of 2 receptors. Therefore, what we do lutetium PSM and lutetium FAPI combined therapy, cocktail therapy, since we get two receptors for the therapy. For prostate, definitely PSMA is better, but always it is good to do a combined imaging of both. In the picture, cuff are different from normal fibrillars, then why can't we differentiate inflammation? Even because of that, even this inflammatory cells few are shown expressing the FAPI. For metastatic pancreatic neuroendocrine tumor, is FAPI better than DOTA? Pancreatic neuroendocrine tumor. It depends upon which grade. If it is grade 1, grade 2, DOTA is better. If it is grade 3, what happens in metastatic tumors? Few of them might be grade 1, grade 2, few might be high grade. Then what we do both FAPI and DOTA, and we get DOTA uptake also, FAPI uptake also, and the lesions which are showing FAPI uptake, that can be targeted with the FAPI therapy. Therefore, combined cocktail therapy of lutetium DOTA and lutetium FAPI is been followed for this neuroendocrine tumor based on the scan. All whatever therapy which we will be doing will be decided based on the scan results. And does FAPI detect insulinomas? Very less experience with insulinoma, but what we always do with insulinoma is we have a very good molecule for insulinoma, what we call it as exendin, gallium exendin. We are happy with the exendin. How days radioisotope secrete from the body after therapy? It is all depends upon the what radioactive molecule we are using. For lutetium, it's a half-life of 6.5 days. It is like almost 7 days. The radioisotope will be, and it is not just based on the half-life of the radioactive molecule. There are different FAPIs available. There is FAPI4, FAPI46, FAPI74, FAPI9, like that. FAPI4 we use for scanning, which has less tumor retention. For example, if I inject, FAPI goes and binds. If I want it for a therapy, I want it to stay for long. Therefore, I am using FAPI9 for therapy. Because FAPI9 stays for 8 to 10 days. It is almost, if it stays in the tumor binding to the FAPI for 8 to 10 days, we can use the lutetium. Lutetium half-life is almost 7 days, 6.7 days. We can use the complete benefit. We can get the complete benefit of lutetium for the therapy if I am using FAPI9, because it stays for longer days. If I am using only FAPI4, it stays for only 4 hours. It is of no use if I am using FAPI4 for therapy, because whatever the lutetium, whatever I have given lutetium FAPI4, it goes and binds there, and it gets detached and gets excreted in the urine. It gets waste. Therefore, always therapy should be done with the FAPI which binds for more number of days. Are surgeons safe after FAPI? Definitely yes. Duration between FAPI and FAPI therapy and chemotherapy, sir. FAPI scan and FAPI therapy, it was discussed. FAPI therapy, it is discussed. Role of FAPI in HCC detection. Definitely yes. HCC, FAPI has a very good role in detection of, not like FDG. It has very good in detection of the liver tumors and also the metastatic disease. In coming to per se, if you ask me about the HCC, FAPI is really, really good. And also then there is something new kid in the block, which is not yet available in the market. It will be coming. A lot of phase 1, phase 2 studies are being done. And that is just like PSMA PET scan for prostate cancer. It is Glypican PET CT scan for HCC. It will be coming in a couple of years, 1 or 2 years. And that is still more better than FAPI for HCC per se, but as of now, FAPI is really good. Sir, since we are destroying cuff cells and soil seed theory, the tumor is responding. So when can we do redo FAPI scan so we can see hence negligible FAPI scan, which amount of response can we recheck with the FDG PET CT? No, better to do with the any PET scan response assessment. Since we would have done with the FAPI, better to do with the FAPI response assessment. We usually do it after the 2 months. We give some time after the FAPI therapy, followed by chemotherapy, then response assessment done after 2 months. Next question is, I've seen more FAPI expression in liver, which is not picked up in CT scan overexpression. Yeah, FAPI scans is better picked up. Liver cancers, HCCs are picked up by FAPI better. Thank you.
Any more questions, trainees?
Which new molecule for HCG? It is glypican. It takes a couple of little time, but we have done some couple of studies. We have seen very better results with glypican PET CT for HCG, and it will be available in couple of years.
So if there are no more questions, shall we conclude the session?
Okay. Thank you all. Thank you, Navneet sir.
So thank you very much, trainees and faculty members, for joining us.